So good afternoon for attending this lecture. Thank you for coming. And for those of you that are online, I say hello. So this is going to take about 45 to 50 minutes. And at the end, so we can have time for questions. For those of you that are online, you can put your question on the chat. So the topic for the day is overview of diabetes. And we are just going through the basics of diabetes. In terms of what we will be covering is going to be we define what diabetes is, discuss epidemiological data, pathophysiology, how to diagnose diabetes, the signs and symptoms, differential diagnosis, some complications, and finally, how to manage diabetes, particularly focusing on our role as a nurse and all other health professionals. The pancreas, which is an abdominal organ, is the organ that really produce the two hormones that we are interested in. So it's both an endocrine and exocrine gland. The exocrine function of the pancreas is for producing pancreatic juice, which go through the pancreatic duct. But we are interested in the endocrine functions, which produce four hormones, particularly it produces glucagon, insulin, somatostatin, and pancreatic peptide. But we are interested in the hormones that are vital to regulation of diabetes, which are glucagon and insulin. In terms of regulation of the blood glucose level, normally the body tries to maintain homeostasis for everything. Maintaining homeostasis for blood pressure, temperature, the body makes sure that the body is in equilibrium, except when there is a pathophysiological condition. If there's no disease, we try to keep the normal values of the body within the normal range. In terms of diabetes, the two key hormones that regulate that particular thing that we are talking about, the blood glucose level, making sure that it's within the normal range, because either imbalance is not good. Hyper or hypo is not good. When there is high blood glucose level, there that is that the signal comes from the pancreas to secrete more insulin, and the insulin will help in terms of uptake of more glucose in the skeletal muscles and making sure that excess glucose is converted into glycogen in the liver. So with that, it can store the glucose away because the body cannot utilize glycogen. Conversely, if there is low blood glucose level, that is reversed, in which case it's going to be the production of glucagon and inhibition of insulin to do the opposite, in which case the glycogen stored in the liver is now reconverted into glucose for us to use and inhibit the uptake of glucose by skeletal muscle and other tissues so that the body can use it. So in essence, it is the interplay of glucose, insulin, and glucagon that regulate blood glucose level. The process being that the insulin helps us to reduce the blood glucose level, promote uptake of glucose by target organ so that more glucose can be withdrawn from the circulation, facilitate conversion of glucose into glycogen, and inhibit the use of amino acid and fatty acid and glycerol to provide energy, which the body will resort to when there is no fuel. Glucagon will do the opposite. Lowers the blood glucose level, inhibits uptake of glucose, breakdown of glycogen, and make sure that it prevents the conversion of amino acid into glucose. So with that, if everything is okay, except when there's a problem like diabetes, things should be okay, in which case the blood glucose level will be within the normal range. So in essence, simply to define diabetes is going to be absence or any inefficiency of the insulin that is produced, which can lead to high blood glucose level. And that is, so diabetes is absence or deficiency of insulin. If it is absence, complete absence of it, which occurs in type 1, that will be type 1 diabetes. Or sometimes you have some degree of insulin, but the insulin is not effective. or the body is sensitive to it, so it cannot do its job as it's supposed to be, which we'll be talking about type 2 diabetes. So in a simple term, diabetes is a metabolic disorder that is characterized by high blood glucose level when the homeostatic level is broken down. What is the problem? The problem is the economic and the human impact of diabetes. The financial cost of diabetes is huge, and the human consequence in terms of loss of hours, absence from work, inconvenience, changes to lifestyle are the issues. So according to this 2014 data, the financial cost of diabetes in the United Kingdom, where we're talking about 9.8 billion, which is estimated to be about 10% of the total NHS expenditure. Majority of the money is spent on managing complications, 7.7 billion pounds, and these are some of the key complications that it is affected: myocardial infarction, impairments of excess inpatient days, because if they then go to hospital, instead of spending 1 or 2 days, they may end up spending 4 days, and that is costly to the NHS, eye problem, amputation, and so on and so forth. So that is why we are interested in diabetes. Again, going forward from 2014 figure, the situation is not getting better. The worldwide figure internationally, diabetes is still on the increase. So currently we are talking about having about 422 million adults with diabetes. And the situation in the United Kingdom also is still not better, it's increasing. So, and that means that we need to do a little bit more. Now, to diagnose diabetes, ideally we will be thinking about making sure that that blood glucose level is between 4 to 7. So that will be an ideal situation, preferably between 4 to 6 millimole per liter. So that will be the best scenario. But again, if we then have a blood glucose test and the blood glucose fasting, when we haven't taken anything, for example, if we need to do blood glucose test, in the GP they will tell us not to eat from last night. If that is done and it is 7 or below, that will be great, but anything above 7, we are worried. If it is random blood glucose level, because we've eaten up to 11, anything above that, we are worried. If HbA1c is done, we want that to be 6.5% and below, because that is going to take the average of blood glucose level within 2 to 3 months. So that's anything above that also, we are not happy. And if any of this is happening, plus signs, symptoms of diabetes, maybe the patient is now saying, I'm weighing a lot, or I'm losing weight, or this is repeated and the result is high at the same time, then we'll be worried. There are some in-between situations. Occasionally, people will have impaired fasting glucose, in which case the blood glucose level is going to be between 6.1 and 6.9. These are people that we need to keep an eye on. Their blood glucose level is constantly high, but they haven't reached the threshold of diagnosing them to have diabetes. So that will be, a worrying situation. And for people with impaired glucose tolerance, say for example, after injecting glucose, your blood glucose level is taken and is above 11 or very close, always in between that, we will be worried as well. Although you need to be above 11 before that is really suggests diabetes. Using the World Health Organization diagnostic criteria, because we are all familiar with the traffic system, green is usually good to go. And this is usually where we are worried about. So according to the World Health Organization diagnostic criteria. When people are fasting, the blood glucose level should be 4 to 6 will be a perfect situation. Brilliant. No diabetes. But when it's now 6.1 to 6.9, that is amber. It is high, but it hasn't reached the threshold to diagnose diabetes. So we need to keep an eye on these people. Impaired fasting, these are some people will call it pre-diabetes, people will say I have mild diabetes or what. So these are the people that we need to keep an eye on. Impaired glucose tolerance, they are just on the high level, but they haven't reached the threshold of diagnosing blood glucose diabetes. But obviously, when it is 7 and above, that is red flag. If it is random venous blood glucose, obviously it's going to be high because the person has eaten. So that's up to 7.8 is good. Between 7.8 and 11, red flag as well, amber. Above 11.1 become a red flag. And the same thing also if the patient has injected glucose. So we have the red zone, the amber zone, and the green zone. So if they are green, no diabetes diagnosis for group at risk, we want to keep an eye on them. We give education on lifestyle. These people, they require monitoring because they are amber color. And at this particular time, we should be offering advice about diet and exercise. This we need to retest because we don't really want to use one test to confirm the diagnosis, and that is why World Health Organization recommend the second test, which is exactly the same thing. But if that is repeated, obviously the RENSO can diagnose diabetes. The common diagnostic technique that we use are urinalysis, which I know some of us are quite familiar. You put the dipstick in the urine and it turns blue. Yeah, then you correlate it with that bottle. That is not often used anymore, but again, it can pick diabetes. If the blood glucose level is very high, it's going to dictate it. And then, so it has a value. Take, for example, if somebody goes for something else and they happen to do the urinalysis, they can pick that up. This is pretty popular, the finger prick test, which we see on the wall, and they calibrate and just match it with the machine. Then we have the random fasting blood glucose level, which we just seen, in which case this is going to be blood sample taken either with we are fasting, we haven't eaten, or we've eaten, and then sent to the laboratory. The fasting one, we said we want that to be 7 at most, and the other one can go as high as 11. This is becoming popular again, expensive, but we have some people having it now, the flash drive, which is now a technology that you just wear in your hand, and then they can just scan it, and then they will read your blood glucose level. Advantage is that then you don't need any finger prick, no pain. But again, it's got its own disadvantage as well, because it's checking the blood glucose in the interstitial fluid, not in the blood. So this will be, but again, you can use that in between and then use the finger prick, which or this that will check the amount of blood glucose in the real blood. Glycosylated hemoglobin is often used as well to check the blood glucose level over a period of time. The lifespan of hemoglobin is about 3 months. So when you now check the amount of glucose that is attached to the hemoglobin, then you are having an average reading of blood glucose level within the last 2 to 3 months. So it's got an advantage that you can have blood glucose level of individual within a longer period of time. Where all this is going to be on the spot blood glucose level, then this gives us a range. The blood glucose level within 2 to 3 months is going to check and then find the average. Again, it's got its disadvantages as well. Take for example, if somebody has got take for example, if somebody has got sickle cell anemia, if somebody has got serious sickness off and on within that period, anything that can increase the blood glucose level, if it's going to be the average, then that can give a false reading. But they are all there and they are all useful technique. So in terms of classification, there are different types of diabetes classification, but World Health Organization also tend to stick to this as an now because you have type 3, you have what any case. So World Health Organization classification type 1, type 2, and others, which are gestational diabetes, impaired fasting, related diagnosed diabetes, all those kind of things. So this is the type. So we stick to particularly the commonest that are type 1 and type 2, and we have the odd ones. So in terms of the role of glucose, insulin. Insulin, when we eat our carbohydrates, like any other food, the end product of carbohydrate, our rice, bread, and so on, is glucose after digestion. Now for this glucose, obviously when we eat after the digestion, the final product goes into the bloodstream. And then we have glucose in the bloodstream flowing. The role of glucose, that glucose in the bloodstream is useless. We cannot use the glucose in the blood. The glucose needs to go into the cell before we can utilize it, and that is the role of insulin. Insulin helps to drag glucose molecules inside the cell where we can use it to provide energy. So when there is no insulin, that means the glucose stays in the bloodstream. You check the blood glucose level, is going to be high, and yet it's useless because we cannot use the glucose. So insulin acts as a key align glucose into the cell where it can then be used as energy by the body. So when the keys are absent, the glucose molecules stays here. Now with insulin, it drags it into the cell, we can use it, then it's depleted, another one we need it, and in that order, rather than accumulating in the bloodstream. But occasionally, that will be the classical description of type 1, in which case insulin is absent. In type 2, you have insulin. Some insulin is either that insulin is not active enough, the body is not sensitive to it, and in which case there's a resistance. In this kind of scenario, then you will have less glucose molecules going inside the cell. So type 1. Previously known as insulin-dependent juvenile or childhood onset, if you read all those old textbooks when we trained as a nurse. So those are the kind of what we didn't have type 1 by then. People juvenile. So, but you really see that term nowadays is type 1, type 1, type 1. These account for about 10% of all diabetes that is people with diabetes. This is about 10% of people with diabetes population. So this is due to autoimmune destruction of the beta cells in the islets of the Langerhans. At the beginning, we said we have two hormones produced by the pancreas from two different cells. The alpha cells in the islet of the Langerhans produce glucagon. The beta cell in the same islets of the Langerhans produce insulin. Now, in the body, we have the immune system. The immunity helps us to fight infection. It is there to fight bacteria, virus, and so on and so forth. And that is what it should be doing. But occasionally, when we now have this kind of abnormality, we are now talking about a situation that the T lymphocytes, the body immune system that is supposed to be fighting external enemies, now happen to recognize these beta cells as more or less an enemy in this case, and is now destroying it. which is not supposed to happen. So it's an autoimmune destruction of the beta cells in the islets of Langerhans, but this is an abnormality because the immune response should really be fighting, external agency. But in this case, you can see it as an antigen, and then it creates an antibody, which then destroys the beta cell, and that invariably means that there will be lack of insulin if this is the structure that is supposed to produce insulin. It's idiopathic and it's long-term condition, and that is why we're still struggling with it. With modern knowledge, it is not under, we don't know why that is happening, and that is why we cannot cure it at the moment. So current knowledge, we can. So it's a long-term condition. That means that the patient will be living with it. So it's all about managing the medical condition, empowering the patient so they can know how to deal with it. So we're talking about absolute lack of insulin, in which case the treatment is going to be insulin administration, because if it is absent, so the treatment will be insulin injection, because again, you cannot give insulin by mouth. So it is sudden onset, but quite a lot of time it will be before 25, but usually it will develop around the age of 4, but most of the time we would have discovered it before the age of 14 years, type 1. But now things are changing, so it can now occur in any change, and increasingly they are now picking type 1 diabetes in older population. So, and that becomes a dilemma. Some people now, so is this not a yardstick to say, okay, this is it, it's type 1. So it's what I've said, the T lymphocytes infect the beta cells and cause cell destruction because it sees this as an antigen that it needs to produce an antibody to fight. So latent phase exists for, and this destruction can go on for quite a while. But by the time that we have about 70 to 80% of the delta cell destroyed, obviously, there will be a problem because you have about 30% function. So 80% of type 1, they normally have circulating islet cell antibodies, probably the anti-GAD, glutamic acid dicarbonase, which is an antibody that is fighting what is not supposed to fight. So these are not autoimmune disease, like when we're talking about probably arthritis and so on. Type 2, which is the second major classification, is formerly not insulin dependent or adult onset. That terminology again, we've dropped it because now you have some type 2 diabetes that now are on insulin injection. If it doesn't respond to tablet, lifestyle changes, they have to go on insulin injection. This accounts for roughly 90% of the cases. It's related in this particular set of people, there is insulin. It's just that the insulin is not sufficient, it's not enough, or the one that is being produced is not active for various reasons. Take, for example, a common cause is overweight, which, because the excess fat makes the body to be sensitive to activity, to the action of insulin. So, but it's not enough, or the one that is being produced is not doing its job as it's supposed to do it. So this is caused by insufficient production or the resistance. It's progressive. Quite a lot of time, this will be picked up when, take for example, somebody just go for a routine checkup, wants to do insurance or anything like that. They just say, oh, we need to do urine test this by this week. And they say, okay, there is blue, turning blue. Okay, we need to do further investigation. So for this particular one, that means lifestyle could be helpful. Diet, exercise, if that is not helping, then they move to tablet. Quite a lot of time, that should be okay. But occasionally, there are few cases that will progress to insulin injection if it's not responding. So type 2 diabetes is what we've said, very similar. You have the stomach, because when we eat all our food, then obviously we digest it. Where the three main food will be the carbohydrate, the fat, and we've got carbohydrate, fat, and protein, the macronutrients, and then we've got the micronutrients that doesn't really require complicated digestion, the vitamins, water, and mineral salt. So, but the glucose is here in the stomach, blood vessels, because it is digested and it goes to the blood vessels. The, so, but what we are now saying is that now we need insulin. This is glucose molecules in the bloodstream, but we need this insulin molecule, the yellow one, to push it into the cell so that it can be useful. And in type 2, you have fewer of this insulin, so to push it. But that means there's still insulin present. It's only so meaning that the pancreas doesn't produce enough. So, and that is why this may not require insulin injection. So risk factor for type 2 diabetes: unhealthy diet. So a carbohydrate diet, not eating, healthy diet, physical inactivity. So those are kind of things. But again, you have some non-modifiable factors. Because if you've got family history, you can't do anything about that. But we are interested in the modifiable factors, things that we can do something about. You cannot do anything about genetics. If you inherit all this HLR, gene, you have tendency to have diabetes. We can't do anything about that. Increasing age is a factor, it's a predisposing factor in type 2 diabetes. We can't do anything. We can't do anything with all this. But we can do something about this. And that is what we will be emphasizing. So we need to eat healthily, exercise, avoid excessive gain weight, check blood glucose level if you think, okay, I feel funny, I'm a bit tired, all these kind of things, and always follow medical advice. And this, according to World Health Organization, the government also has got a role to play in terms of, healthy environment. If you say we should do exercise, the government should be providing parks for us where we can go and walk. Otherwise, if they are failing, but again, yes, but all this again depend on where you live. Yeah, more money, buy you a better something, a better environment with green area. So again, but that's a different issue. Then collecting the data and making sure that equipment, reagent, treatment, whether they are expensive or whatever, are available. These signs and symptoms are pretty similar but can be more severe and peaked earlier in type 1 diabetes. Usually people talk about the 3 Ps: polyuria, polydipsia, and polyphagia. People urinating more, because when you have excess glucose in the body wants to flush it out. The process of excreting the glucose will need to pass more water and the glucose can go out. When you lose more water, obviously you feel thirsty, because dehydration leads to feeling thirsty. And then because the carbohydrate that you have, the sugar that you have, you can't use it to feel hungry. Because you can't use the glucose as well, you feel tired. Because it's in the bloodstream, you can't use it to provide energy, tiredness. Again, if you cannot use the glucose, the body tends to turn to all this fat, burning fat, to provide energy, loss of weight. And also, excess glucose has got the ability to damage blood vessels, which tend to happen very quickly, not in the severe, also in the eye. And that can, manifest as a blood vision if that can be picked before it gets worse. So in terms of the difference between the two, age, type 1 will usually happen before age of 40, type 2 usually about 40. These type 1 people and people like slim like me and things, but commonly type 2 people again are frequently overweight, but that doesn't mean that somebody like me cannot have type 2 as well. This is autoimmune destruction. This is not an autoimmune destruction. It's insufficient or resistance. This is absolute. This has got some degree of insulin relative. And then definitely this set of type 1 people depend on external, the insulin that is produced. But they may not need it and they may not need it. Again, another key major complication is DKA. DKA is more common in type 1, less in type 2, but again, people with type 2 also can have DKA. It's not common in them. Another one of the rare type is gestational, which is pregnancy-induced diabetes. So Again, this is pregnancy-induced insulin resistance abroad. Usually, you pick it up in the second or third trimester of pregnancy. When it is discovered within the first 3 months, it's likely to have existed before, but it was not diagnosed. So at this particular time, because the body cannot produce enough insulin to meet the demand of body imposed by pregnancy. So occasionally in the first pregnancy, the first 3 months, trimester is the first 3 months. So in case if it is in the first 3 months, it's likely that the situation would have existed before that particular time. It's just about 5% of pregnancy. So 95% of pregnant women will not have gestational diabetes. Women who are overweight are at risk. Family history is all those kind of things that put people at, or previous uh, gestational diabetes, and then you are having second pregnancy, all those are disposing factors. But people that has got gestational diabetes, they have tendency to develop type 2 diabetes when they are no longer pregnant. And again, we try to encourage them if they can breastfeed. That could be helpful as well, because breastfeeding, you use energy as well. So that can drop the blood glucose level, because you need energy to. So children born to mothers, they tend to have big weight. They can have stillbirth. They tend to have, even with birth, they tend to have, and they too have tendency to develop diabetes as well. We've said that one of the predisposing factor is family history. Uh, so this also is an issue. Now, we've said there are different types of orders. Another example is latent autoimmune diabetes of the young. These are another type of diabetes that is being picked up, but this happens late 30s to 40s. Quite a lot of time they don't need insulin. They refer to as latent autoimmune diabetes of the young. This also is, can't control this as well, because this is due to mutation, genetic accident. So again, is something that can happen to it's a random something. But the only problem that instead of happening very early, this comes a bit later. And there's issue about diagnosing this, because we tend to think, okay, if it's age, this should be type 2, but again, yeah. But if you are worried about diagnosis, there are two key tests that can easily be used. You can check the GAD test or the C-peptide test. That will help us to differentiate. We are now having some type of diabetes that doesn't conform to the norm of this particular age. But we can't do for type 1 diabetes. If you do the GAD test, the GAD antibodies will be positive, because we have said this is an antibody that is produced to fight, because it recognizes the beta cells as an antibody reaction. So this will be present. But for type 2, obviously, there won't be GAD antibody, because it's not an autoimmune disorder. Also, if you do the C-peptide here, it's going to be low. Then you will know it's type 1 diabetes. The normal C-peptide is 5 to 20. But because C-peptide is a substance that is produced during the production of insulin, so that means if it is high, there's production of insulin. The higher it is, the more likely that will be type 2. So formed during conversion of proinsulin to insulin. So high levels suggest that there's some residual beta cell function. But if this is low, that means there's less insulin production, and that will be type 1 diabetes. So in case when we are not really sure, is this type 1 or is this type 2, then you can do the C-peptide test, or we can do the GAD antibody test to confirm, and then that let us know this is type 1, this is type 2. So again, we saw in the previous slide about complications. That is gotten a lot of money in terms of the NHS finances. So we have different types of, in terms of acute complications, the two commonest is hypoglycemia. Hypoglycemia means low blood glucose level. The other time we said homeostasis is maintaining balance. Either way is not good, low or high. The same thing with blood pressure, hypertension, hypotension. None of it is good. Hypothermia. So the best thing is, so we have a situation by which the blood glucose level also can be lower than normal, and we use 4 as the floor. So blood glucose level below 4 millimole per liter is regarded as hypoglycemia, and that has got issue as well. People getting shaky, and they can't get worse to confusion. And these are the common causes of admission to ITU and so on if it's get. And they can become unconscious. If they become unconscious, then we treat as normal, but for unconscious hypoglycemic or DKA, we use the ABCDE assessment, the same way that we assess, and then treat other things that is necessary. Diabetes ketoacidosis is another situation that is, these are the two commonest emergency. Also, when there is no insulin, to drag glucose into the cell, the body will source for alternative fuel. If you cannot get glucose to provide energy, then the body will look for alternative fuel. The fuel is usually commonly turns to fat that we get from our pork, all those butter and so on. Now, the conversion of fatty acid and glycerol to energy, you have a byproduct, which is keto. And that is what brought the diabetes ketoacidosis. There is no glucose to produce energy. The body then turns to fat to provide energy. The byproduct of that process is keto, DKA. So you have ketone that is higher than normal. You have blood glucose. Obviously, blood glucose must be high, because if there's insulin, there's no insulin, this is high already. It's turning to fat to produce. The byproduct of that is keto. And then we have acidosis. If you check the pH value, it's less than 7.3. Those are the classical signs. Again, these are serious emergency and they are life-threatening situations. So usually it can be due to intercurrent infection or interruption of insulin. Quite a lot of time, maybe accidentally inject insulin into the muscle, or occasionally you are using pump, the pump has dislodged. All those kind of things do occur. And these are acute complications. The other acute complication, we still have euglycemic ketoacidosis, a situation by which the blood glucose level is normal, but you have keto. Very rare. You still have all this hyperosmolar hyperglycemia, by which you have high blood glucose level and dehydration, then there is no ketone. So we still have but these are two common type of acute complications, life-threatening, and they are very serious. Then along with that, we have some complications that happen gradually over a long period of time that we refer to as long-term complications. This we saw in the slide in terms of the financial cost. So we've said that high blood glucose level over a long period of time has the ability to damage the blood vessels. It does cause narrowing of the blood vessels, and when that happens, it means reduction of nutrient and oxygen to that particular structure. If it then happens in the coronary artery in the heart, then you have all this coronary heart disease. It can happen in the cerebral artery that supplies the brain, in which this can lead to things like stroke. It can happen in the vascular disease, the leg, and then you have all these wounds. And that is when it happens in big blood vessels, the macrovascular. But it can also happen in the microvascular, the tiny blood vessels as well, which we refer to as microvascular disease. Damage to the small, tiny blood vessels in the eye, in the retina, which can cause retinopathy, and that is why some people with diabetes will go blind. It can cause retinal detachment, macular edema, swelling, and so then loss of sight. Also, the tiny blood vessels in the nephron. If it happens there, then we'll be talking about nephropathy. Again, if it gets worse, some people end up with kidney transplant, which is an expensive product anyway. Then it can damage, the same processes can damage the nerve, which we refer to as neuropathy, and the event happens, that is when you see that people lose sensation in the leg. They can't, the loss of feelings, all those, and it is neuropathy also that causes things like erectile dysfunction. That is the process by which it affects, ability to do other things as well. So now, in terms of what we've said, what is important is making sure that we control the blood glucose level tightly so that we keep things within the target for the person. This is a very big study, popular, the diabetes control and compliance trial, in which case you see when the HbA1c is low, this is 6%, 7%, 8%, 9%, 10%. When it's low, all these apart from hypoglycemia, retinopathy, neuropathy, nephropathy, microalbuminuria, all these are very low as well. As the HbA1c, when the blood glucose level continues to rise, we can see increase in the number of all these complications. The only trend that we have that goes the opposite direction is hypoglycemia. That's the only one that is going in the other direction. So again, when we are trying to tightly control blood glucose level, we still need to keep in mind that we need to balance how to drop the blood glucose level without causing hypoglycemia as well. So it's all about making sure that we control the blood glucose level very well. Okay, in terms of treatment, the common treatment are these. One is, when it comes to type 2 and even type 1 anyway, this will be helpful. We all need balanced diet. That will comprise protein, carbohydrates, fat, water, mineral, salt, and vitamin, everything must. The only thing is the adjustment that we need in terms of carbohydrates. So eat all types of and choose fibers kind whenever possible. Choose lower fat. Try not to eat too often when you do have small of fat. But again, what this is emphasizes low carbohydrate diet and a lot of vegetables and greens. Exercise, we know we need to burn out fat because we've said that it's a predisposing factor in insulin resistance. And when it comes to treatment, if it's type 1, it's going to be insulin. For other, it's going to be, for type 2, it can be tablet alone. So for type 2, we be diet, this, and tablet in most cases, but occasionally they can graduate to insulin. And then these are just medium of administering insulin. Insulin can be, this is still available, withdraw and inject, but again, pens are becoming far more popular because it's easier. You don't need to withdraw, it's just a cartridge. So, and then occasionally insulin pump, but these are just ways. So this is insulin. It's just ways of administering insulin. So glycemic index, people need to know about the glycemic index of the food. And what this means is that when we talk about carbohydrate, there are some carbohydrates that will raise the blood sugar level very quickly. And some will raise the blood glucose level gradually. So you tend to have high glycemic index, medium glycemic index, and low glycemic index. And depending on what is happening, for example, if somebody has got hypoglycemia, you want to give a food that has got high glycemic index, food that will raise the blood glucose level very quickly. But if it is contrary, you have it. And these are just examples. So if somebody has got hypo, you want to go to high glycemic index. Stepwise management of type 2 diabetes. The way we manage is diet and exercise. Recommendation is that all these 150 minutes per week if you can do it, but not short beat. So 30 minutes strenuous active on the go. And then diet with your same diet. Then we go to one tablet. If that's commonly, they start with sulfonylurea or bigonad, metformin. And if that is not working, they go to oral combination of two drugs, which is what we do for any other medical condition as well. If you've got hypertension, if you have one tablet, if they've reached the maximum limit of that drug and they cannot increase the dose, obviously they had another one. So you add another one. When you reach the maximum limit that you can give for one tablet, you add another one. And if that is not working, there are some occasions that you can have up to 3. And also, then the next thing is that they go to insulin at GLP-1 plus oral agent. Insulin is always injection. This is there because this is not insulin, but it's injectable. So it's like you have a pen as well, but it's not insulin. Glucagon-like peptide 1 agonist. They are anti-diabetic agents, hypoglycemic agent. They lower the blood glucose level, but it's not insulin, but it's injection. So, and that then the oral tablet, all these are with the tablet. So injection, tablet kind of thing. So pharmacological management, I'm not sure whether so, but what we is just nice guideline. So type 2 diabetes in this, what you choosing person's individual clinical circumstances, you consider individual preferences according to NICE guideline. So, and then all the drugs are here, and that is the way it tells us, the doctor also, anybody that is prescribing whether diabetes, what to give first, what to move to next, all those kind of things, you see. So consider DPP by metformin not at high risk of cardiovascular. Metformin, this if you need to combine, how you can combine, everything is here. So there are different types of drugs, how you can combine them. And again, if you need to things that we need to consider before prescribing. Take for example, sulfonylurea offers weight gain. If somebody is obese before, you don't want to give that. So whereas then you can go down the effect on weight, you go down the route of all this metformin. So again, all those kind of consideration. So in terms of pharmacology, it's nice guideline. They are there. What you need to give first, if you need to, if you need to combine, what you can combine, what you cannot combine. They are all there's a guideline. And for all those DKA and hypoglycemia as well, you have all those protocols in the trust as well. Each trust we have DK guideline. Yeah, this is how you manage it, what you do. So in terms of insulin, these are the 3 common characteristics of onset of action. When will it start working? When will reach its peak? And when will it, reach the maximum strength? So, and that is what, and we use 3 types of the human's insulin. But when you need a quick action, then you give rapid acting insulin. You've got the short acting, the intermediate, and the long acting that can. So in which, because it's just 3 things. Onset of action, this works within 15 seconds, 15 minutes. The actions kick in. So again, take for example, if somebody is going for surgery, if somebody has got DKA, you want a rapid acting that will start immediately. So and then you've got, but again, you will go for long acting insulin that will be a little bit late before starting action, but longer, then in which case then the patient will have less dosage because it can be in the bloodstream for the next 24 hours, and these are different types of insulin. Role of the nurse. So we've got, because of the problem that we've got a role in terms of diet, physical activity, maintaining normal body weight, but as a minimum, this is what is being recommended that as a minimum level, we have 15 healthcare essentials for everyone with diabetes. As healthcare professional, checking the blood glucose level, because they are bad twins, all this cholesterol, because we've said glucose, high glucose already is capable of damaging the blood cells over a long period of blood vessels. So blood and all these complications can quickly lead into renal problem. So checking blood cholesterol, the role of cholesterol also in terms of all this arteriosclerosis and kind of thing. Eye screening, because of the damage that it can cause to the eye, doing annual checking with the foot and leg check, because foot care also, and you tell them to be wearing something, not to walk barefoot. Kidney test, kidney function test, advice on diet, emotional, again, because it's a long-term condition, people feel frustrated, tired, all those kind of things. Education, ideally, according to the National Framework for Diabetes, which is a legal requirement, is that anybody diagnosed with diabetes should be referred for diabetes education. So they have to go to be taught what is diabetes, how to care for it, all those kind of things. care for the referring to diabetes specialist, not free food jab. So good care again, because in the hospital there's been some cases that even patients admitted in the hospital, sometimes they do develop decay and hypoglycemia, and that shouldn't really be happening. So support with any sexual problem, help, because again it's a sensitive issue, people don't want to talk about it. You've got to initiate this, in a clever way. So help with any sexual problem, help to stop smoking, and if they are planning to have pregnancy, obviously with the what we've said in terms of even gestational diabetes, they need to, and as soon as they are pregnant, midwife, all those checking blood glucose level, making sure that things are all right. Ideally, people should really be in their house, because all what you have to empower them. Role of the nurse, the previous two slides, you need to empower them. Health education in the previous slide also is about empowering the patient so they know what they do. So they don't run to us all the time. So they can't manage their condition. But these are common causes when they have infection. Infection, anything that causes stress will cause, or infection, all these causes, some counter-regulatory hormone, usually the release of adrenaline, or this the catecholamine, they increase blood glucose level. Uncontrolled diabetes, which can be due to lack of knowledge or whatever, particularly the elderly when they've got diabetes. This is they come with dehydration and chest infection, deranged kidney function. Obviously, that will have implication for the drug if there is problem with the kidney. Occasionally, some people will come to the hospital to start insulin, so you can know to gauge what will be the appropriate dosage for them. Foot ulcer, there's a lot of things in terms of people with a lot of amputation, decay and hypoglycemia, the commonest acute complication. When people are newly diagnosed, again, lack of knowledge. And occasionally, people will go for preoperative care. Take for example, what some other people will come in for as a day case, if it's a patient with diabetes, we want them to be in, check things and make sure that you have a proper preoperative assessment. Occasionally, things will still not go according to plan. And these are some of the reasons. Compliance is, there's a lot of literature on compliance. Again, they may be worried about side effects. If the drug is causing something that they don't like, we've got some that cause loss of libido, weight gain, all those risk of maybe the patient has got hypoglycemia before with sulfonylurea, then they are scared, then they don't take it as appropriate. Risk of weight gain, not attending appointments, and even poor concordance with lifestyle. They still don't exercise, they still don't eat well. Motivation, lack of patience. Again, there's a lot about patient-centered care. When you come together, kind of shared decision making kind of thing, they tend to engage more rather than thinking you will tell somebody do this. They are not likely to do it. But again, collaborative approach does help knowledge. And again, some we have mental psychological factors, existing mental problems, stress, experience with maybe his mother has died of diabetes, is know this is going to happen to him or her anyway. Difficulty, sometimes denial, some people still don't, they still know, is frustration, why me, all those kind of things. And then we've got interference with lifestyle, employment. If I'm a teacher now, if I happen to be here every day, I'm at that desk, it affects blood glucose check, it affects, eating habits. Yeah, if you are stuck somewhere 9 to 5, you just make, if you want to go for the appointment, maybe I will need to tell my manager that I'm sorry, I can't no, I can't come to. So all these kind of can make this issue. And sometimes when people have some drugs that can again increase blood glucose level, some steroids and all these, some antipsychotic drugs that also raises infection, and again injection technique. That is because it has to be subcut. So pinching and things, by the time we go too deep, then it becomes intramuscular injection. That means the injection will not get used, and then we have all these kind of complications. And that does happen with nurses as well. In summary, so diabetes, locally, nationally, and internationally, is still rising. So we still need to do a little bit. It's got a lot of, consequences in terms of personal, financial, social. If you need to go out, you have to adjust, make some adjustments. Others are eating this, I cannot eat it. So we have all those consequences. And type 1 is autoimmune deficiency, autoimmune disorder, and we need insulin. Type 2, obviously, is just a situation by which is sufficient or the one that is there is not complete. Glycemic control reduces, so we have really as nurses make sure that we control this blood glucose level tightly. It may be challenging without having, but again, this is what, and our role as healthcare is professional is quite important. I think. Yeah. Thank you. I think try to be on time. Thank you.
And Muili, if that's okay, I'm just going to see if there are any questions online as well.
Okay.
So,
all right. Thank you.
no, there are not any questions.
Okay. Things that I would like to clarify. Okay.
Apparently, if you eat a lot of rice, it adds on the diabetes as well, or it allows you to have diabetes. And is that true? If you eat a lot of rice or like no spaghetti, pasta. Because I like eating that, so I just want to know.
It shouldn't be really. We're talking about if everything is all right, you don't have tendency to have diabetes before, genetic reason, due to other reasons, inactivity and so on, you should burn it off anyway in my situation. And the body should be able to maintain that equilibrium.
I was wondering if vitamin D can be a predisposing factor to type 2 diabetes.
No.
Lack of vitamin D.
No. Lack of vitamin D will not have any connection with diabetes. Vitamin D has to do with all these bone teeth kind of thing. So it doesn't really,
It might give you similar symptoms though, like fatigue, mightn't it, if you're vitamin D deficient. But it's not related.
Okay, because I read something.
If you are diagnosed with diabetes, it's not from your diabetes, it's not from vitamin D.
I read something like that, so I was wondering what's that actually asked you.
No, it will vitamin D deficiency will not cause. It will not cause diabetes. But obviously you could have problems with cheat foods and so on, tiredness, yes. But definitely not diabetes. Okay.
I'll ask you a question.
Okay.
So what about, so you mentioned risk factors like family, so genetic. What about cultural groups? Are there particular cultural groups that are more at risk of diabetes?
Yes, the Black and South Asian community are more at risk, and yes, when it comes to the diabetes.
Do you know why? So I'm pretty on the minute.
Yeah, the reason being that, again, when people come to another country, I think they take the disease profile of the country. Take, for example, when we are talking about quite a lot of it is one, it could be due to genetic factor if their parent has got that particular medical condition. Take, for example, the type of diet they eat. Then, most importantly, lifestyle. Again, they don't fit in some area. Take, for example, if I'm a South Asian lady, that another man cannot see my thigh, and you are not telling me to go to gym. They have all those cultural limitations that will not allow, particularly when it comes to exercising and things, because they just don't see why. So they've got lack of exercise, which could be due to cultural factors, beliefs as well. Even when people are told, okay, you've got maybe impaired fasting glucose or whatever, they still don't believe that, okay. And even among the Black, there is even an experiment that is going on in London, that they are even giving the pastor tablet to give them. It's just belief. My God, my Jesus will not allow. So we've got the role of belief, cultural factors, not being able to socialize in that kind of particularly when it comes to exercise. And quite a lot of times, sometimes also they have all these high carbohydrate diet. with less activity because of this environment.
It goes back to that rice again.
Yeah, but
But
she's
only-
young.
But it's a, yeah.
The thing is that because I
Lifestyle.
exactly I go gym. That's when
Yeah,
you talk
yeah.
about physical. I'm
Yes.
happy because I'm quite
Then you will
balanced.
burn
Exactly.
it. And yeah, because take for example, it's normal. That's what it happens here. Quite a lot of black ethnic minority also they have diabetes here. But sadly, when you go to their country, they've got low diabetes rate. But again, they do more exercise. The environment is favorable. The environment here, I hardly work myself as well. So yes, when I if I don't get a parking space, I run away very quickly, particularly when it's cold. So the environmental factors could really and all those add up and then, but generally, in terms of epidemiological data, we have diabetes is more prevalent in South Asian and black ethnic minority. Yeah, when you compare to the white, Caucasian group. So you have high prevalence among the black and ethnic minority South Asian.
Sorry, can you have a question? Can surgery fix diabetes type 2? Surgery.
We won't go down the route of surgery. Why we don't want
Pancreas.
to? Anyway, the type of surgery that you will be
Pancreas
thinking anyway, you can. So it's not popular anyway, but I will be thinking of type 1 diabetes, be thinking about probably pancreas transplant. But again, all this is an expensive, particularly it's an organ that we only have one. It's not like so yes, but pancreas transplant as a last, yeah, but very rare.
Very
Yeah. But that is the structure that we need to really fiddle with.
Okay. You were saying that HbA1c would be one of the tests to do the pre-diagnostic the diabetes, right? But you were saying it might be skewed in those with sickle cell.
Yes.
Yeah. So how much would it be skewed, and would you actually predict a normal HbA1c level in somebody with sickle cell?
What is the straightforward answer is that there are category of people that you say is not recommended as a diagnosis, yes, because if they've got issues with their hemoglobin. That's the problem. These glucose that attach to hemoglobin, they've got a medical condition that affects the hemoglobin. So the result, so it's not recommended.
So what sort of exact investigation would you be using for those with?
You can still do all these fast, all those blood tests, the needle prick, all others will be perfect. Because that one will give us on the spot level. The problem with that is, is an average. And if somebody has got a blood disorder, or how do we call it, anemia, obviously it's not recommended. Yeah, it's not recommended. Yeah. It's not recommended.
Okay. All right.
Oh, there's one more.
I'm just wondering if someone is having gestational diabetes. Is it advisable to tell that person to stop diabetes?
It depends. If that is your first pregnancy, do you say you won't have a baby? I won't go that line. That would be going too far. I would say if somebody has got gestational diabetes, you manage anyway, the patient is just special care. Yeah, making sure that from the beginning, the person is being managed because the diabetes specialist, gynecologist, midwife, multidisciplinary, working together to achieve the best result. Having said that, individuals have tendency to have big baby, they have tendency to have stillbirth, they may likely have complicated labor that may be CS, labor may be induced more quickly. But it depends, but I don't think it will be a good reason just to blanket something to say no. If
where you remember things like it's
Yeah.
person-centered care
Yeah.
and it's patients, if they're informed and understand the risks. That's their choice. They've made that choice. It's why it's so important that people are educated about it so they can make an informed decision. But as nurses, our job is to not be judgmental when we are advising our patients. It's to be offering them information, but not expecting that they will do what we would do, or even what we would want to, or what we would like them to do. They have a choice. We have to accept that. It's not always easy.
It's a big thing.
If they have capacity to make a decision,
Yeah.
then they can choose how they live their life.
Some people will decide not to have a child. Yes, with or without diabetes. But if that is going to be the reason, I think you can't go down that route straight away that because of this.
Some will desperately want children,
Yes.
but know that having a child and diabetes, particularly type 1 diabetes, will put a tremendous amount of pressure on the rest of their body, their kidneys, but they'll know this, but they've made the choice because what they want is the child.
Yeah, so the
And our
advice
job to support them and advise them and make sure they've got all the MDT care that they need in that time.
and they know the risk that this is high risk. You could have a preeclampsia. It's just letting them know. But you won't say don't be pregnant.
Or don't do this again.
Oh,
We're booking you for a
One very common presentation with gestational diabetes is that they usually come hand in hand with hypertension. And so you will see that if they have gestational diabetes, you see that they also have a very common presenting symptom, which is hypertension. And then we have to be careful about how to manage them, because there will be a high risk of preeclampsia.
yes. Yeah. So, but they just need to know. We won't say don't be pregnant.
And actually, I was going to say that if someone has maybe if a pregnant person does a glucose tolerance test and their sugar level happens to be very high, it's worth testing again, because I know someone who had a test and was very high, and the person referred to the diabetic team, not because the person was have diabetes, but the person was going a lot of stress or something. So I think it was just a stress that was the person's sugar level, and the person had to test it and all of that. So we want testing to make sure that this person definitely has high glucose level, not just.
They are all the tests that we've mentioned, but interestingly, OGTT is one of the key recommendations when people has got gestational diabetes. Is one of the most valid tests that a patient with gestational diabetes need. But in that case, we don't know what has happened. But again, things do. Yes.
Use the error. I mean, you could have had someone not clean skin properly. And
Yeah.
there's all sorts
Yes.
of
Okay.
reasons
Yeah.
and things like that can happen. It's why you've already told us that they should have 2 tests before the diagnosis is made anyway, because there is potential for these errors.
False result, yes. Maybe the person, all those kind of things do cause problem. But the person still need to keep an eye on it. I will still say they can still do all those needle prick tests and things and keep an eye to see what has happened. But having said that, stress can increase blood glucose level or those kind of. But to get to a level that they will be thinking of gestational diabetes.
Like in a few years, and the person has got all that, the person is not diabetic, it's been like 8 to 9 years, the person is fine. So it's just something that went wrong at that point.
Yeah, but even people with gestational diabetes, some people will get away after that pregnancy. It's pregnancy induced. Pregnancy induced. If the person after delivery, exercise, diet, good lifestyle, and there's no any other underlying condition, that may be the end. But they have tendency to have type 2. They have tendency, but that doesn't mean that that person will be. I don't know what has happened in that cardiovascular scenario. But they have tendency to develop type 2 diabetes later in life. That's the way it should work. But we always have outliers, people that will not conform to that particular,
It's no such thing as normal, right?
yeah, some people will always deviate from the norm.
Thank you.
Really?
So thank you very much. Thank you. How did we get here?
Show us all your emails.
No, yeah, because I'm not gone. I not got to my email when I came here. That's why. Thank you very much.
Yeah, cut it.
You see.